Welcome, everyone. In this explainer, we're going to tackle one of the most intellectually demanding concepts in electrocardiography, and that's the world of complex arrhythmias. We are going to take a very deep dive into the fascinating, and yes, sometimes confusing relationship between the atria and the ventricles to really understand what's happening when they appear to fall out of sync.
So let's start with this rhythm strip right here, because it's a perfect example of the challenge we're up against. At first glance, the P waves and the QRS complexes, they seem to have no relationship whatsoever. It's like they're marching to the beat of two completely different drummers. This apparent chaos is a classic diagnostic puzzle. And this brings us right to the core question we need to answer. Are we looking at what you might call a broken bridge, a complete pathological failure of the conduction system between the atria and ventricles? Or is there something more subtle going on here? Something like a temporary disconnect that's just caused by timing and the natural physiological refractory periods of the heart's own cells?
Okay, so to get to the bottom of this, we're going to build our case step by step. First, we'll cover the fundamental principles of cardiac conduction. Then we'll explore the concept of reciprocal beats and reentry. After that, we'll get a really precise definition of AV dissociation, and then we'll learn the key diagnostic clues to look for: capture and fusion beats. And finally, we'll put it all into context and touch on the subtle phenomenon of ventriculophasic arrhythmia. All right, let's dive right in. Before we can even begin to interpret a complex arrhythmia, we have to ground ourselves in three absolutely fundamental physiological rules. These rules, they dictate every single interaction between a P wave and a QRS complex. Period. There are no exceptions. So, think of these as the three pillars of PQRS interaction. First, cardiac tissue has a built-in recovery time after it fires. That's its physiologic refractoriness. Second, the conduction system is not a one-way street. Impulses can travel both forwards, or anterograde, and backwards, retrograde. And finally, the third pillar. As long as the heart muscle isn't in that refractory recovery period, it will respond to any electrical impulse, no matter where it comes from. Okay, so with those rules in mind, let's see what happens when that two-way pathway creates what you might call a glitch in the system, basically an electrical feedback loop. This phenomenon is called re-entry, and it is absolutely key to understanding a whole host of fast heart rhythms, the tachyarrhythmias. And this leads us to something called a reciprocal beat. Now, a more precise term is actually a reciprocating beat. This happens when an impulse travels down one pathway of the AV junction, and then, because of the presence of dual pathways, it can turn around and go back up the other one to reactivate the very chamber it just left. It's like an electrical echo. What's so great about this diagram is that it shows us just how versatile this mechanism is. A reentrant circuit can be kicked off by an impulse from the sinus node, from the AV junction itself, or even coming backwards from the ventricle. Each one of these scenarios can produce that reciprocating or echo beat. Let's look at this specific example. Here, a sinus impulse, which we see as P1, travels to the ventricle down a slow pathway. We know it's slow because of that long PR interval. Now, that delay is absolutely critical because it gives the atria just enough time to recover from their refractory period so that the impulse can zip back up a fast pathway, reactivating the atria and creating that second P wave, P2. That is a perfect atrial echo. All right, so now that we have the concepts of refractoriousness and reentry under our belts, we're ready to tackle our main topic: atrioventricular dissociation. This is that state of organized chaos we saw in the very first ECG, where the atria and ventricles just seem to be doing their own thing. Now, the formal definition of AV dissociation is simply a state where the atria and ventricles beat independently, each controlled by its own pacemaker. But, that definition on its own is incomplete. The really critical diagnostic information isn't just in observing the dissociation, but in figuring out why it's happening. What is the underlying cause? And this right here is the crucial distinction to make. AV dissociation without a block is purely a physiological timing issue. The conduction bridge is perfectly intact, but an impulse happens to arrive when the system is refractory and can't respond. Complete or third-degree AV block, on the other hand, is a pathological problem. The bridge is structurally broken. No impulse is getting through, no matter what the timing is. So how can we actually prove that the AV conduction bridge is still working during an episode of AV dissociation? How do we know it's not a complete block? Well, the answer lies in looking for two very specific, highly diagnostic clues on the ECG. These events are the definitive proof we need. The first clue is called a ventricular capture beat. This is the definitive proof of anterograde conduction. It happens when a sinus impulse arrives at the AV node at the absolute perfect moment, right after it's recovered from its refractory period. This allows the impulse to conduct normally down to the ventricles and capture them, producing an early QRS complex. Take a look at the complexes labeled C on this tracing of ventricular tachycardia. You can see their shape is that of a supraventricular beat, and they happen earlier than the underlying ventricular rhythm. This single beat proves without a shadow of a doubt that there is no complete AV block. The bridge is intact. The second hallmark we look for is a fusion beat. Now this is really interesting. It happens when a descending sinus impulse and an ectopic ventricular impulse activate the ventricles at the exact same time. The QRS complex that results is a hybrid blend, a literal blend of the two different activation wavefronts. Now what's so cool about this slide is the shape of the F complexes. Look closely. They're not fully wide like the VT beats, but they're not fully narrow like the capture beats either. They are a true intermediate hybrid, which visually confirms that the ventricles were depolarized from two different directions simultaneously. And just like a capture beat, this proves an intact anterograde pathway. Okay, so now that we're armed with these diagnostic tools, we can start to reframe AV dissociation correctly. See, it's not a diagnosis in and of itself. Instead, it should be seen as an obligatory secondary response to some other underlying primary rhythm disorder. You'll see AV dissociation pop up commonly in settings like these. The unifying principle here is that there's a lower pacemaker, either junctional or ventricular, that is sped up to a rate that's similar to, or even faster than, the sinus rate. This creates a kind of physiological competition for who gets to control the ventricles. So let's go back to our very first ECG. Here we can see an accelerated AV junctional rhythm emerges. Then, as the sinus rate slows down just a bit, the P wave drifts into the QRS complex. What happens? Well, the sinus impulse arrives at the AV node only to find it refractory from the junctional beat. And at the same time, the junctional impulse tries to go backwards and finds the atria refractory from the sinus beat. The result? AV dissociation, purely due to physiological interference and timing. And this strip is just a fantastic illustration of the dynamic nature of this competition. As that junctional impulse travels backwards, we first see fusion P waves, marked with an F. Then we see full retrograde capture of the atria. And finally, as the sinus rate picks back up, it reestablishes control, first of the atria, and then it successfully conducts down to capture the ventricles, restoring normal sinus rhythm. It's a beautiful demonstration of intact bidirectional conduction. All right, finally, let's address a related and really subtle phenomenon that can sometimes mimic other conditions. It's an important differential diagnosis when you're looking at rhythms that seem to have a 2-to-1 atrioventricular relationship. And this is called ventriculophasic sinus arrhythmia. It's an observation, and you see it in about 30 to 40% of cases of complete AV block. And what you see is that the P to P interval that happens to have a QRS inside it is just slightly shorter than a P to P interval without a QRS. The proposed mechanism? The idea is that the ventricular contraction itself, either mechanically or autonomically, influences the SA node, causing it to fire just a little bit sooner. This diagnostic table provides us with a really crucial framework for telling these tricky rhythms apart. So if you see 2 P waves for every QRS, look very closely at the timing. If that P to P interval is perfectly regular, you're looking at a 2-to-1 AV block. If the P to P interval that contains the QRS is shorter and the P waves look identical, that's ventriculophasic sinus arrhythmia. But, and this is key, if that P to P interval is shorter and the P waves have different shapes, your diagnosis is actually non-conducted atrial bigeminy. And this brings us to the most critical clinical takeaway from all of this. Understanding that AV dissociation is a secondary response, it's a symptom, not the primary problem, fundamentally changes our entire approach. Our goal isn't to treat the dissociation we see on the ECG. Our goal is to find and to manage the underlying cause, whether that's something like digitalis toxicity, ischemia, or some other primary electrical disorder. That shift in focus is the absolute key to effective clinical management.